I'm pleased to introduce Dr. Jörg Ehrman, who will speak today on spondyloarthritis, including psoriatic arthritis. Dr. Ehrman, thank you for joining us today.
Thank you for the introduction and good afternoon, everyone. So the title of my presentation is Spondyloarthritis, including psoriatic arthritis. These are my disclosures. And this is the general outline of the talk. I will first give an overview of spondyloarthritis, will then touch on some treatment aspects and end with the problem of diagnostic delay in axial disease. So spondyloarthritis is a family of inflammatory rheumatic diseases with variable involvement of the axial and peripheral skeleton. Spondylos and arthros are the Greek names for vertebra and joint. And so spondyloarthritis can be translated either as inflammation in the spine and arthritis, or inflammation of the joints in the spine. Either way, it highlights the fact that there's very prominent involvement of the spine, which sets this family of diseases apart from other types of rheumatic disease, such as rheumatoid arthritis. The spondyloarthritis concept has evolved over the last 100 years, and that is shown on this slide here. So there are three phases that we can distinguish. The first phase started in the early 19th century and lasted until the mid-20th century. And during that phase, the disease entities that we now consider to be part of the spondyloarthritis family were described. So that includes psoriatic arthritis, ankylosing spondylitis, reactive arthritis, and IBD-associated spondyloarthritis. The second phase, from the mid-20th century until 1974, was characterized by the recognition that these disease entities were different from rheumatoid arthritis, and ultimately they were recognized as a family. And this process was because of the result of some scientific developments. First, in the 1940s, rheumatoid factor was discovered, and it became clear that these diseases that you see on the bottom left here, that patients with these diseases are rheumatoid factor negative or seronegative, different from rheumatoid arthritis. And then the second major development was the discovery of the association of the MHC class 1 allele HLA-B27 with ankylosing spondylitis in 1973, and shortly thereafter, the other diseases that are part of the spondyloarthritis family were also shown to be associated with HLA-B27. So this resulted in a seminal paper in 1974 that defined the family of seronegative spondyloarthritis. And today we just say spondyloarthritis because there's no such thing as a seropositive spondyloarthritis. So we might as well leave this out and avoid confusion with seronegative rheumatoid arthritis. The most recent phase was then or has been characterized by attempts to classify diseases, develop criteria, and again there has been some major involvement of scientific progress. In this case, the development of MRI, and so in the early 90s it was shown that patients with spondyloarthritis and axial disease had MRI, had sacroiliitis on MRI, and subsequently similar findings were shown for the spine. So let me briefly introduce the four disease entities that we consider to be part of spondyloarthritis. First, ankylosing spondylitis. So in the classical description of this disease, this is a condition that affects predominantly young men, male-female ratio of 2 to 3 to 1. There's a strong association with HLA-B27. And the disease is characterized by chronic back pain and stiffness that results in reduced mobility. These symptoms are the result of inflammation both in the SI joints and also elsewhere in the spine. And this can lead to bone remodeling, pathological new bone formation, the formation of syndesmophytes at the edges of vertebral bodies, and ultimately ankylosis of the SI joints and the vertebral and the spine, and that results in permanent dysfunction and loss of function. In addition to disease of the spine, there's often involvement of large joints, in particular the hips, and patients with AS can also have extra articular disease manifestations, most commonly uveitis. The picture on the left shows an individual patient, the course of an individual patient with essentially untreated ankylosing spondylitis. At the very left, he probably presented, and at that time, with symptoms such as back pain and stiffness. And at that time, his physical examination was probably completely unremarkable. And so it took a while for him to probably get a diagnosis. And this resulted in the development of a new disease entity called axial spondyloarthritis. So this is a broader category that includes a larger number of patients, probably twice as many as who have ankylosing spondylitis. And so this category includes patients with AS, but also patients who have similar symptoms, but they don't have the characteristic X-ray features that patients with AS have. However, when their SI joints or spines are imaged with MRI, inflammation can be seen. So importantly, in these patients with non-radiographic disease who don't have the X-ray findings, the male-female ratio is 1:1, suggesting that male sex controls the progression from non-radiographic to radiographic disease rather than disease susceptibility per se. Other factors that affect this disease progression are high inflammatory disease activity and also smoking. It has been shown that up to 40% of patients who initially presented with non-radiographic disease progress to having radiographic disease over the course of 10 years. So that means that a substantial number of patients will never progress. These are the classification criteria from 2009 that initially defined this entity of axial spondyloarthritis. Patients can be classified in two different ways. One arm involves imaging of the SI joints plus disease features of spondyloarthritis. The second arm is called the clinical arm on the right. And so patients can also be classified by having a positive B27 and at least two of these clinical features. However, it's important to realize that these are classification criteria, and if these are uncritically applied to making a diagnosis, this will lead to frequent false positive or false negative diagnoses, or at least there's a danger of that. So here we have a typical case of a patient with non-radiographic axial spondyloarthritis. A 28-year-old female presents with chronic low back pain. This started insidiously about 2 years ago. She has seen chiropractors and massage therapists. The pain localizes to the low back and buttocks. It's worse in the morning and sometimes wakes her up from sleep. She also complains about prominent morning stiffness. Symptoms improve with exercise or ibuprofen. She has no history of peripheral arthritis, but she had an episode of uveitis in the left eye 1 year ago, and she has her father has psoriatic arthritis. Exam is unremarkable. CRP is within normal limits. She's HLA-B27 negative, and the initial radiograph of the pelvis showed normal SI joints. However, a subsequent MRI, which you can see on the right here, shows that there was inflammation around the SI joints. And what we are looking for is bone marrow edema as the best sign of active inflammation in the SI joints, shown in this patient in both SI joints. The other thing I want to highlight is that she has a specific type of back pain called inflammatory back pain that has certain characteristics and distinguishes this pain from garden variety mechanical back pain caused by injury. So it starts insidiously and typically gets better with exercise and is associated with morning stiffness, lasting more than 30 minutes typically. So there is a number of criteria that have been developed for inflammatory back pain, starting with the Kalin criteria in 1977. They have in common that they all have a sensitivity and specificity of around 80%. So this means that inflammatory back pain can be seen in patients who don't have an underlying inflammatory disorder. And not all patients who have axial spondyloarthritis or AS have inflammatory back pain. So that's an important thing to consider, but it is a good screening tool. This flow chart shows you how one can approach, actually make a diagnosis. I don't want to go through this in detail. I just want to highlight the elements that are part of the diagnostic process. Very important is history. So what's the characteristics of the patient's back pain? Is there a family history of spondyloarthritis? Then laboratory tests are the CRP and HLA-B27. Imaging of the SI joint is part of that, initially an X-ray, and if that is normal or equivocal, then an MRI of the SI joints. And the exam often does not contribute much because the spinal exam can be completely unremarkable initially. However, we are trying to look for extraspinal disease manifestations such as psoriasis, enthesitis, or arthritis in peripheral joints. So secondly, psoriatic arthritis, which is a major group within the spondyloarthritis family. It can affect both the axial skeleton, but more commonly the peripheral skeleton. Up to 30% of patients who have psoriasis, and that is a substantial percentage of the general population. So up to 30% of psoriasis patients may develop an inflammatory arthropathy over time. In most cases, they first have the psoriasis and the joint involvement develops subsequently. There's a number of different subtypes, different types of involvement of the musculoskeletal system, which I will show in a second. In addition, dactylitis and uveitis are very common. So this slide shows you a few of the different variants of psoriasis, plaque psoriasis on the top left, but then there are also other variants such as guttate psoriasis, inverse psoriasis on the right that can mimic Candida infection, palmoplantar pustulosis in the bottom center, and then various types of nail disease. Nail disease is frequently associated with DIP arthritis. Enthesitis is common. I want to make the point with this cartoon here that entheses are everywhere in the body, and if they get inflamed, they can give rise to pain. The typically or most commonly affected entheses are the large entheses of the lower extremities, such as the Achilles tendon insertion at the calcaneus. Dactylitis is a very typical feature seen in psoriatic arthritis, also called sausage digit or sausage toe, and this is the result of widespread inflammation involving soft tissues, the tendon sheath, and the joints. And then uveitis is also very common. Both anterior and posterior uveitis can be seen in spondyloarthritis. Anterior uveitis involves either the iris or the ciliary body, and then choroiditis would be an alternative term for posterior uveitis. And the presentation of a patient with uveitis involves or can involve eye pain, eye redness, and visual changes. So this slide shows you different joint involvement patterns in psoriatic arthritis. I already mentioned that some of them have axial disease, a typical presentation that's also distinct from rheumatoid arthritis is asymmetric oligoarthritis, in particular involving the lower extremities. DIP arthritis, as shown in the third skeleton here, is associated with nail disease, but some patients may also have asymmetric polyarthritis that is similar to rheumatoid arthritis. Two additional less common variants of spondyloarthritis are reactive arthritis and IBD-associated spondyloarthritis. Reactive arthritis is different because it's an acute disease. It starts by definition within 4 weeks after a urinary tract infection or an infectious diarrheal illness caused by gram-negative bacteria. The term reactive arthritis was introduced in 1969, although the disease itself was described much earlier. And reactive arthritis is the currently preferred term over Reiter syndrome, which was in common use in the US until the early 2000s. Reactive arthritis can in 50% of patients become chronic, and then the treatment is similar to the other types of spondyloarthritis, which we will review. Disease manifestations are very similar to psoriatic arthritis, except for the lack, for the presence. So they don't have the psoriasis, but keratoderma, blannorrhagica, and circinate balanitis are disease manifestation or skin manifestations that can be seen in reactive arthritis. An important issue is that although there's an association with the preceding infection, the synovial fluid culture is always negative, and that sets a reactive arthritis apart from septic arthritis that you just heard about in a previous presentation. And then finally, spondyloarthritis or inflammatory arthropathy is the most common extraintestinal manifestation of inflammatory bowel disease, and both peripheral arthritis and axial disease can be seen. Spondyloarthritis is often shown as a Venn diagram of overlapping circles. So why is there this overlap? So there's overlap at different levels. There's overlap because the different diseases involved share certain disease manifestations. For instance, enthesitis can be seen in AS and PSA in the other variants. There's also overlap because individual patients may actually fulfill criteria for more than one of these entities. I have a patient who has at the same time ankylosing spondylitis, peripheral psoriatic arthritis, and Crohn's disease. And then thirdly, there's overlap because of shared genetic risk factors and shared disease mechanisms that has some impact on how we approach the treatment in these patients. However, there are also distinct features, and that is shown here. So for instance, when you compare the results from genome-wide association studies, some genes, some risk genes are shared between IBD, AS, psoriasis, and psoriatic arthritis, such as genes involved in IL-23 receptor signaling, but there are also distinct associations, for instance, ATG16L1 and NOD2 are only associated with IBD and not with the spondyloarthritis variants. So let's talk about treatment. There's a number of treatment recommendations that have been published over the last few years for axial spondyloarthritis, AS, and psoriatic arthritis. And we use these to extrapolate to the treatment of other spondyloarthritis patients who do not fit into these distinct categories of axial spondyloarthritis or PSA. So what are the sort of the basic features of treating spondyloarthritis? Number one, the treatment options that we have available differ from rheumatoid arthritis. So some of the drugs that are used to treat RA don't work in spondyloarthritis. Classical example is methotrexate, which has some utility in treating peripheral disease in PSA, but does not work for treating axial symptoms in axial spondyloarthritis or AS. But other examples exist, such as interleukin-6 inhibitors or abatacept, which don't work for axial disease. The important classes of drugs in spondyloarthritis are nonsteroidals as the first-line treatment, TNF inhibitors, and then the inhibitors of the IL-23, IL-17A axis, although there are some differences in how different diseases respond to these drugs. And then a new class are the JAK kinase inhibitors. I put them in brackets here because the clinical trials, phase 3 clinical trials, for instance, for axial disease are still ongoing. Treatment decisions in spondyloarthritis can be complex and need to be individualized because it is a heterogeneous group of disorders. So it matters, for instance, whether a patient has predominant peripheral disease or predominantly axial disease. It matters whether the peripheral disease is arthritis or whether the patient really has enthesitis that causes the symptoms. And then it's also important to consider the presence of extraskeletal disease manifestations such as psoriasis, IBD, or uveitis. So I have a couple of slides that show data from papers. So like this one here, this is a recent study that compared IL-17A inhibition and TNF inhibition in psoriatic arthritis, and it shows that IL-17A inhibitors are clearly better in treating plaque psoriasis on the left, but there was no difference in the response of the arthritis in the patients in this study. On this slide here, I compare the result of IL-23 inhibition in psoriatic arthritis, and this was a clinical trial of peripheral disease, with IL-23 inhibition in axial disease in AS. And what you can see is that the patients with psoriatic arthritis responded to this drug, whereas patients with AS who were treated with the same regimen, same dosages, had no benefit from IL-23 inhibition with ustekinumab. And why that is still a matter of debate. I will skip this. This is from the GRAPPA recommendations for PSA, and it makes the point that it's really important to consider the different disease domains in the individual patient in order to come up with an appropriate treatment plan. In addition to drugs, non-pharmacological interventions are also important, and that includes physical therapy, in particular in patients with axial disease. So PT has an impact on symptoms, but it's also important in patients with ankylosing spondylitis to maintain function and maintain range of motion in the stiffening spine. Weight loss is important in patients with psoriatic arthritis who are often obese, and it has been shown that weight loss improves the response to treatment with pharmacotherapy. And then smoking cessation is important in addition to all the other benefits of smoking cessation. It is important because smoking is a risk factor for radiographic progression in ankylosing spondylitis. Spondyloarthritis are inflammatory diseases and associated with an increased risk for cardiovascular disease. So risk factor management is important. And then finally, many of our patients are on biologics, and so certain rules apply here. So patients on biologics should receive vaccines for pneumococcal infections. They should get the shingles vaccine. And treatment with biologics is a contraindication for live vaccines. Finally, a few slides on the problem of diagnostic delay in axial spondyloarthritis and AS. This is something that was recognized many years ago. This is a frequently cited study from 2003 that shows that there is a substantial delay of up to 10 years between onset of symptoms and diagnosis. Now, has this changed? And although there's some debate about this, these recent studies show that it doesn't look as if the diagnostic delay has been getting shorter. So where's the problem? And it's probably a number of things that contribute to this. So that includes that patients, are young. Back pain is very common in the general population. They may have been sent, or they may be sent to orthopedist chiropractors initially. There are no specific physical findings, no biomarkers in early disease. And paradoxically, the good response to nonsteroidals that we see may also contribute to a delay in diagnosis, because patients may self-medicate with over-the-counter drugs. But one factor is also a lack of awareness in primary care and other patient and other healthcare providers who see these patients. And so that's why it's important to talk about that. So what is important here? So the most important thing is to think about the possibility of axial spondyloarthritis in a young adult who presents with chronic back pain. So it's important to ask about pain characteristics and then consider the other factors that I mentioned earlier when we talked about the diagnosis of axial spondyloarthritis in making potential referral decisions. And it has been shown that this can be effective. There was a number of studies, mostly from Europe, that showed that using a number of simple screening tools, the frequency of spondyloarthritis patients spondyloarthritis could be increased to up to 35% in patients referred to a rheumatologist. And I think that's ultimately the important thing. If there is a suspicion or a possibility that a young patient may have an underlying inflammatory disease, then they should be sent for rheumatology evaluation. So this is my summary. Spondyloarthritis is a family of inflammatory diseases with overlapping clinical features. Axial disease includes ankylosing spondylitis, but also patients with non-radiographic disease who don't have the typical X-ray features, but they have similar symptoms and a similar disease burden. And the treatments that are used are non-steroidals, TNF inhibitors, and inhibitors of the IL-23, IL-17A axis. So we have a few questions. Question number one. Which of the following is a feature of inflammatory back pain? A, morning stiffness lasting less than 30 minutes. B, sudden onset within 1 month after urinary tract infection. C, no benefit from oral nonsteroidals. Or D, improvement with exercise but not rest. All right, and we had a good number of answers. So the correct answer is D, improvement with exercise but not rest. B, just to remind you, is the criterion for reactive arthritis. Second question. Which of the following is true regarding the treatment of spondyloarthritis? A, methotrexate is the first-line treatment for all variants of spondyloarthritis. B, the treatment approach for psoriatic arthritis and rheumatoid arthritis is largely identical. C, IL-17A inhibitors are more effective than TNF inhibitors for treating psoriatic skin disease. Or D, IL-23 inhibitors are more effective than TNF inhibitors for treating the back pain in axial spondyloarthritis or AS. All right, so there was a bit of a toss-up between C and D, it seems. And the correct answer is C. IL-17A inhibitors are more effective for treating skin disease than the TNF inhibitors. It may have been a little confusing. So the interesting thing is that the IL-23 inhibitors actually do not work for treating the spinal inflammation and axial disease. So D is incorrect and C is the correct answer. And last question. In a 30-year-old male with inflammatory back pain and normal radiograph of the SI joints, the most appropriate next diagnostic step is A, obtain a room panel, B, an MRI of the SI joints, C, an X-ray of the cervical, thoracic, and lumbar spine, or D, a PET-CT. All right, and very clear, almost all of you have this correct. The correct answer is B. An MRI of the SI joints is the next step. X-rays would not be sensitive to show and would likely not show anything at this point. So an MRI of the SI joints is the next step. And that is the end of my presentation. There should be some references which will be in the syllabus, I'm sure. Thank you.
Well, Dr. Ehrman, thank you so much for an outstanding talk.